All right, we'll call to order the December 6th meeting of the Health Insurance Reform Commission. Would staff call the roll?
Delegate Bourne. Delegate Goditis.
Here.
Delegate Ware.
Here.
Senator Saslaw. Senator Surreville.
Here.
Senator Spruill.
Here.
Secretary Walker-Harris, represented today by Melissa Asselone. Commissioner White. Vice Chair Heritic. Chair Barker.
Here.
Mr. Chair, you have a quorum.
All right, we will start off with, now after this, with the second item on the agenda, the Step 2 assessment of House Bills 2669, 503, and House Bill 503, and Senate Bill 382.
Well, good afternoon, Mr. Chairman.
Sure.
My name is Jamie Bitts, and I will be presenting to you the findings from JLARC's review of the proposed prosthetics mandate.
Okay.
And the slides should be making their way up fairly soon. All right. All right.
Once more, please. Once more, please.
I can do it. All right. Sorry about that, Mr. Chairman.
Quite all right.
Just by way of background, JLARC is responsible for stage 2 of the health mandates reviews, and as part of that, we look at 3 questions. First, whether there's evidence that the proposed treatment is effective. Second, how commonly used and available the treatment is. And third, what's the out-of-pocket cost to a person when the treatment is not covered by insurance. We don't look at whether the proposed mandate would result in costs that the state would have to defray. That's something that is addressed by the Bureau of Insurance as part of their portion of Stage 2. Just to summarize our findings briefly, HB 2669, the proposed mandate, would change the existing requirement in code that insurers offer coverage of prosthetics. It would change that to a mandated benefit. The proposed mandate may also expand coverage of electric prosthetics to more amputees in Virginia. In addition, in our research, we found that electric prosthetics can provide greater control and balance for amputees, but that a relatively small number of amputees in Virginia are using these devices. And then finally, we found that electric prosthetics generally cost substantially more than the body-powered devices. I have 4 parts to the presentation this afternoon. I'll start with some very brief background information. Now, the best estimates suggest that nearly 2 million people across the U.S. live with limb loss of some type, whether it's an arm or a leg, for example. That number is expected to increase substantially over the next several decades. Based on the number of people nationwide living with limb loss, there are an estimated 43,000 people in Virginia alone living with limb loss. In terms of the types of limb loss and their causes, the vast majority of amputations are to lower limbs. Roughly 70% of all amputations are caused by vascular diseases like diabetes or peripheral arterial disease, and these are the most common causes of lower limb amputations. Then it's about 30% of amputations that are caused by some sort of trauma, and that is the most common cause of upper limb amputations. Now, there's an extremely broad range of prosthetic devices potentially available to amputees, but they generally fall into one of 2 categories. One is body-powered prosthetics, the more traditional type of prosthetic, which is typically controlled by the amputee through a system of cables and pulleys. The other category is electric prosthetics, and these are typically controlled, at least in part, by electric sensors in the device itself. Myoelectric devices are a type of electric prosthetic that is for the upper limbs. They move when their sensors receive electrical signals from the amputee's residual limb. And then microprocessor devices are electric prosthetics for lower limb amputees. Sensors in those devices control the knee based on the terrain that the person is walking across, as well as the way that the person is walking in terms of their foot speed and their gait movement. The bill we reviewed, HB 2669, would require private insurance plans and the state employee health plan to cover medically necessary prosthetics. It specifically requires coverage of the repair, fitting, replacement, as well as related components. The bill also requires insurance plans to cover any electric devices that have a Medicare code at this point. And then in doing the research for this review, we found at least 20 other states around the country that require some sort of insurance coverage for prosthetics. I will say that across these states that are highlighted here, there is quite a bit of variation in terms of the type and extent of coverage. And now I'll take just a couple of minutes to talk about the medical efficacy and the use of prosthetic limbs in Virginia. Generally speaking, prosthetics are critical for amputees to regain their functionality and their independence after an amputation. Limb loss can obviously limit a person's ability to do a wide range of things. It can also lead to secondary conditions like mental health problems and a sedentary lifestyle, which of course has its own set of conditions that can result. And a prosthetic can, as it should be a surprise to no one, can help an amputee get back at least some of that independence and some of that functionality. It is important to understand, though, that not all amputees will need a prosthetic. Whether one is needed and the type of prosthetic that would be described or prescribed depends heavily on how functional that person was before the amputation. And so, for example, if it's someone who had very little mobility prior to the amputation, they may benefit very little, if at all, from a prosthetic leg. Now, because the proposed mandate could expand coverage of electric prosthetics, we looked specifically at these devices. We found strong evidence in the research literature that microprocessor knees can reduce the number of falls by an amputee. Those devices generally improve balance and overall satisfaction for the person. There are a smaller number of studies that have looked at and have found that myoelectric arms can improve control for those amputees and also improve their overall satisfaction. Because it's a smaller number of studies, there is the need for additional research to confirm those findings there. The medical experts we talked to said that electric prosthetics are an effective treatment for certain amputees, and that they're most appropriate when the amputation is above the elbow or above the knee. And I'll have more to say about when electric prosthetics are the most appropriate versus a body-powered in just a couple minutes. Now, medical experts also emphasize that the type of prosthetic needed depends on the unique circumstances of each amputee. That's ultimately determined by a physician. And one of the things they're looking at when they're considering whether a body-powered or an electric prosthetic is the most appropriate is the individual's functional level. Generally, an amputee with a higher functional level will require a prosthetic device that is more complex. And so, for example, an amputee that needs fine motor skills for their work may need a myoelectric arm that gives them greater control and fine motor ability in order to do their work and return to the workplace. On the other hand, an amputee that has cognitive limitations, say for example from a brain injury, may be better suited for a body-powered device because electric prosthetics generally require more training and more cognitive ability on the part of the amputee. A body-powered device may also be best suited for someone who, for example, spends a lot of time outdoors, maybe their work is outdoors, and that's because those types of devices tend to be more durable and less affected by moisture and dirt and other outside factors. Now, a relatively small number of amputees in Virginia are receiving electric prosthetics. We looked at data on the types of devices that have been covered through UVA's health system and then the state employee health insurance plan for FY21. And for both of those plans, less than 2% of the charges were for electric prosthetics or their related components. And the medical experts we talked to also said that it's a very small number of amputees in Virginia that are actually receiving those electric devices. That partly reflects the most common types of amputations that are occurring. For example, amputations that are above the knee are less common than below the knee amputations. And in the case of below the knee amputations, there obviously isn't a need for a microprocessor knee. By the same token, relatively fewer upper limb amputations are above the elbow, and so there's less of a need there for a myoelectric arm that provides the ability to pivot the elbow. Now, electric prosthetics are more commonly provided through the Veterans Administration for both current and past members of the military. The VA's clinical guidelines actually recommend the use of microprocessor knees in order to reduce falls and to maximize overall satisfaction for amputees. But it's important to emphasize that even through the VA, the type of prosthetic that's prescribed really depends on each amputee's individual circumstances. Mr. Chairman, I have a couple slides just on the financial impact of prosthetic devices when they're not covered by insurance. Electric prosthetics generally cost much more than the more traditional body-powered devices. And the table on slide 17 shows you the range of costs for each type of device, depending on whether it's for an upper or lower limb. So you can see that a body-powered prosthetic leg can range from $1,000 to $4,000. A microprocessor leg, on the other hand, can range from $15,000 to upwards of $50,000, and sometimes even more. To give you an example, the microprocessor legs that were covered through the state employee health insurance plan in FY21 they cost up to $24,500. There are additional costs for related components and fittings and things like sockets for amputees that are getting any kind of prosthetic device. And so, for example, the cost of a socket, which is just where the prosthetic device fits into the residual limb of the amputee, that can vary widely just depending on a number of different factors. One thing to keep in mind in terms of cost is that electric prosthetics generally need to be repaired and replaced more often than body-powered devices. The electric devices are more complex, they're more sensitive to moisture and dirt, and they're just more prone to wear and tear. And so, for example, a microprocessor leg may need to be replaced every 3 to 5 years, whereas a body-powered device will typically have a much longer lifespan. I guess I'm going to ask you next slide. Was working. There we go. And finally, I'll talk about, for just a couple of minutes, about how coverage of prosthetics would change if the proposed mandate was passed. Next slide, please. As you may already know, insurance plans are required to provide some coverage of prosthetics. The Code of Virginia requires plans to offer a policy covering them, and insurers are providing varying levels of coverage for the actual devices as well as their repair and replacement. And more to the point, individual and small group plans are covering prosthetics to some degree as part of the state's essential health benefit plan. Prosthetics, including electric devices, are considered on a case-by-case basis by insurers. Some electric devices are covered right now, but others are still considered experimental by insurance plans. Next slide, please. Mr. Chairman, this slide is just to remind you that proposed health insurance mandates only apply to about a quarter of individuals in Virginia. The remaining 3/4 of people are in plans like Medicaid and large self-insured plans that are regulated at the federal and not the state level. Next slide, please. If the proposed mandate were passed, it would expand coverage of prosthetic devices in Virginia. It would do that by changing, as I mentioned earlier, changing the existing provision that insurance plans offer coverage, changing that to a mandated benefit requiring their coverage. And importantly, it would expand the types of devices covered to include more microprocessor legs and myoelectric arms. Next slide. Mr. Chairman, that's everything that I had planned to talk about, but I'm certainly happy to answer any questions there may be.
All right, are there any questions?
Mr. Chairman.
Yes, Senator Thurable.
Thanks. I had a question about the number of people you said are living in Virginia that have limb loss. Given the large number of veterans that we have and how many folks we've had come back from Iraq and Afghanistan, IEDs, et cetera, and I know my predecessor's husband, for example, I know stepped on a landmine when he was in Vietnam and had multiple limb losses. I was just curious what percentage, if you had any idea how many of these 43,000 people were actually already covered by the VA or not?
Unfortunately, Senator, I don't. It's a very rough estimate based on a nationwide estimate of the number of people living with limb loss. When we did our research, we found it very difficult to find any kind of numbers that gave us a good sense of just how many amputees were living in Virginia. And so that's an extrapolation from that nationwide estimate. My guess is that it probably includes some members of the military that have come back from recent conflicts and that have suffered the loss of a limb. But I'm also going to guess that it probably excludes a number of them as well.
Mr. Chairman?
Yes, Senator Thurable.
Two other questions. I guess then the U.S. Census, that's not, I don't remember ever answering that question, but that's not a question they ask. And number one. Number two, in your survey of any other states that you looked at, do any other states differentiate between people that already have coverage to the VA or people that don't?
I'm not aware, I guess to the first question, I'm not aware of any kind of question like that being asked as part of the census. As far as research into other states, we did look at whether states had mandates that required coverage in any way, but I think typically state mandates requiring private insurers, for example, to offer different types of coverage or require coverage of different sorts would not apply to the Veterans Administration because that would fall into that category of federally regulated insurance plans and programs.
Thanks.
Yes. Delegate Ware.
Thank you, Mr. Chairman. I have a question. I'm not sure if it's for yourself or maybe there may be somebody else, but I have read testimony that the current mandated offer has had the practical effect of making this coverage pretty widely available in that 1/4 of Virginians segment that is out there. Do you have any sense of how widespread that coverage is based on the mandated offer?
I don't, to be honest, Delegate. It was very difficult for us to figure out of those individuals, for example, through the UVA health system or the state employee health insurance plan, of those who received or anybody who needed an amputee or a prosthetic and sought one. There wasn't any data on instances where they were denied coverage and therefore couldn't get one. So I can't really speak to, other than anecdotes we've heard, I can't really speak to how often those aren't covered.
Mr. Chairman, I wonder if there would be somebody, if you would indulge me asking that question more widely at this point, or is that appropriate to the juncture where we
Yeah,
are?
that would be fine to ask that now, so.
Thank you.
See if anyone has any information on that. Does anyone in the audience have any information? No. Yes,
Mr. Chair,
yes. Mr.
this is
Gray,
Brad Marsh with the Bureau of Insurance.
Okay.
And my presentation will touch at least on coverage and where it exists in those markets when we move on to the BOI part of the step 2 analysis. And if
All right.
that doesn't answer Delegate Ware's question, we can follow up then, and I'll try to give some more detail.
all right, why don't we, yeah, we'll, we'll see if there are other questions now, and then get the presentation from the Bureau of Insurance. Any other questions? All right, then let's move to the presentation from the Bureau of
Thank you,
Insurance.
Mr. Chairman.
Was there somebody said something? Okay. All right,
Mr. Marsh, whenever you're ready, go ahead and share your screen and begin your presentation.
All right, will do. All right, can you all see that?
not at the moment.
One moment, please, Mr. Marsh.
No problem.
All right, Mr. Marsh, could you try starting again, please?
Sure.
And could you speak into the microphone so that the camera picks up your presentation?
Sure, yes. Need that in order for it to recognize the sharing. Would you like me to stop sharing? Share again? No.
Just keep speaking into the microphone. It looks like we can see your screen share presently.
No problem. All right. I'm going to go ahead and go to full screen mode here.
Yeah, please try that.
All right.
Perfect. We can see you clearly, Mr. Marsh.
Okay. Looks like you guys are seeing are you seeing my presentation screen or the one that's supposed to show to me only?
Your presentation screen.
Okay. Excellent here. Okay. So my name is Brad Marsh. I am the health insurance policy advisor for the Bureau of Insurance, and I'll be going through the other aspects of the step 2 that are the BOI's responsibility with respect to the prosthetics mandate. Here's a slide that sets forth the elements of the BOI section of the step 2 review. What we're looking at here is the expected impact on utilization of services, the expected impact on premium costs, which includes the administrative costs to insurers, the expected additional cost to the state under the PPACA, which is the cost of frail that we've discussed at some prior meetings here for things that are mandated for QHPs. And lastly, the expected impact on the total cost of healthcare in the Commonwealth. We did, and these next couple of slides will apply both to the prosthetics mandate and to the breast milk mandate that we'll be discussing next. For our previous step 2 analysis, we relied on surveys of carriers to determine the impact of utilization. Carriers were not able to provide this information for prosthetics or for the pasteurized donated human breast milk mandate. The prosthetics mandate, the reasons for this was that the prosthetics mandate defines medically necessary device in a way that would impact carriers' utilization review processes because it would mandate that these devices are medically necessary, and instead of going through their standard process for ensuring that that what the services the individual gets is actually medically necessary. And then for the donated human breast milk, there was a lack of clarity on how coverage for that service would be operationalized, and the range of potential outcomes did affect the carrier's ability to estimate impact. So we did not receive the standard type of data that we normally base our analyses on. And so that is all to say that we've done our best to come up with a fiscal impact based on other information, but it's not based on the information that we normally get from carriers. And I believe that if you have other questions about the reasons for that, Doug Gray and VHP may be able to answer those more specifically as to what those challenges were. House Bill 2669, as Jamie already spoke about, it repeals the existing mandate to offer and changes that into a mandate to provide coverage. And it adds a definition of medically necessary prosthetic device, which includes myoelectric, biomechanical, or microprocessor controlled prosthetic devices. Current prosthetic coverage in Virginia, because the Affordable Care Act requires non-grandfathered health plans in the individual and small group markets to cover EHPs, and prosthetics is included in Virginia's benchmark plan, and as such is considered an essential health benefit. There is coverage in the individual and small group markets currently for prosthetics. In the large group market, insurers are required to offer employers the option to purchase prosthetic coverage for their employees at additional cost to that insurer. So in the current environment, the large group market would be the one place where in that 24% that Jamie was talking about, where there is not currently a requirement to provide prosthetic coverage. And then VHP indicates that the definition of medically necessary prosthetic device could be an expansion of coverage from the current EHPs. And because of the impact on their service authorization and their medical necessity determinations, there could be additional costs on top of what sort of the current mandate to provide would be if there were additional electric devices that would be covered that may have not been determined to be medically necessary prior to the definition within the bill of all of them as medically necessary. So because prosthetic coverage is currently in HB, the main impact would be to mandate coverage in the large group market. Although the addition of these electronic devices could increase utilization to some degree, in the individual and small group markets where there's already a requirement to provide these prosthetic services or prosthetic devices. JLARC's research, as Jamie mentioned, showed that less than 2% of prosthetic-related billing was for electric prosthetics in places where they were covered, which does account for, it does mean that it would be a fairly small impact if the impact was to be the same as it exists in the current market. Although I think there might be some concerns by the carriers that the preempting of their determination of medical necessity might result in more unnecessary or things that would not have qualified under their current practices to be billed for, and might end up with something greater than this 2% of prosthetic related billing that is the experience in the state employee plan and the UVA health plan. And then lastly, and we've discussed this, and the Deputy Director of Life and Health, Julie Blauvelt, discussed this at our last meeting, but under Virginia Law 382-6506A1, exchange plans in the individual and small group markets would now be prohibited from providing this benefit. QHPs would be prohibited from providing this benefit in an attempt to sort of preempt the defrayal costs that we'll be discussing a little bit later on. And this is just a slide from Ms. Blauvelt's presentation at the last meeting, but the main goal of this 382-6506 is by prohibiting QHPs from providing these state mandated benefits that are not included as an EHP. And as we noted before, the existence of a mandate then identifies whatever's in that mandate as an addition to EHP, regardless of the fact that those services and devices may have been provided prior to, as a result of different rules here, as a result of them being in the benchmark plan. So that the effect of mandating this would be to define prosthetic devices as in addition to EHP for these purposes. And so, as we noted in our presentation at the last HERC meeting, there is a conflict there between this law and a federal prohibition on segmenting the small group and individual markets between QHPs and non-QHPs. And CMS has indicated to us that if left as is, there's the potential that that could result in the coverage of these services being required by QHPs and could result in the state being responsible for those defrayal costs. So because we do have this coverage existing already in the individual and small group markets, we have some idea of what the PMPM cost is from a report that they provide to us on an annual basis that looks at the carrier's total cost for covering these mandated benefits. Carriers in the individual market reported a cost of about 12 cents per member per month for covering mandated prosthetic benefits in plan year 2019. With administrative costs, this amounts to about a 16 cent per member per month cost for just particularly for these prosthetic services. And while we don't get reports on the small group market specifically broken out for the small group market, looking at the per member per month over the entire group market, it does imply that the cost in the small group market is similar to that 16 cents per member per month with administrative costs. Now, carriers in a large group market where this would be a newly mandated benefit would likely see a similar per member per month cost of services of about 12 cents. With administrative costs, this results in a 15-cent increase in monthly premiums. And the difference in that 15 and 16 cents is results from the different medical loss ratios that are required in the large group versus the individual and small group market. The large group is an 85% MLR versus in the small and individual, we're looking at about an 80% MLR, which affects our estimated or implied administrative cost that we add on to there. So the only new healthcare costs are in this large group market, and where that 15 cents per member per month equates to about 1.1 million annually based on 2020 enrollment. Individual market costs for providing prosthetics are estimated to be $485,000. 93.1% of these individual plans are QHPs and then would be prohibited from providing this prosthetic coverage that they currently provide. They would be prevented from doing it by this. And this would result in an actual reduction to the overall cost, at least to the carriers, of $450,000. The small group costs are estimated to be about $600,000 annually, but only about 1.4% of small group plans are QHPs. So the vast majority of those small group plans would be required to cover prosthetics under this mandate. Overall healthcare costs would be reduced by about $8,000, and that's just 1.4% of the 600,000 there, and that would be the QHPs in the small group market who would now be prohibited from providing these services that they had been providing. This is where it gets a little bit complicated here in terms of what the Affordable Care Act defrayal cost would be as a result of this. If the Virginia law is applied as written, there would be no defrayal cost because coverage would be prohibited for the QHPs. But if, as we mentioned before, the federal law were to preempt prosthetic, and that would mean that prosthetic coverage were mandated in the small group and individual markets, Virginia could be required to defray the cost of those services and equipment to the tune of around $460,000. That is the end of my presentation.
All right. Are there any questions?
Can we get that in writing?
Mr. Chairman, Senator Serval, apologizes for not having a copy in front of you. My machine broke today, and so I only had limited copies of various presentations.
Can somebody email it to us, or?
Yes, sir.
To him, I don't need it.
Yeah.
Thanks.
All right. Quick question. There were a variety of different expenditures per year that were talked about in your presentation. What was the $1.1 million per year, and what was the $460,000, and were there other figures that we should be contemplating if, and particularly given the situation as the potential for the state having to defray the cost?
Sure. So the $1.1 million is in the large group market, and that would be
which group market?
The large group market.
Okay.
Yes, and that's the large group market with the federal employee health plan removed from that because this would not apply to them. That 1.1 million would not be something that that the state would be responsible for defraying. It would just be a cost that would be accounted for in the per member per month increase in charges and premium within the large group market to cover these services that are not currently covered, except for in a mandated offer situation.
Why would we not be potentially subject to the defrayal of the cost?
Because the deferral of the cost is only for the QHPs and the market plans, and that those are not in there.
Okay.
Those do not exist in the large group market.
All right.
So it's about the exchange, the plans that are on the exchange, which are for the most part the individual market. However, there's a small percentage of the small group market that is covered on exchange, that 1.4%. And then I believe your other question was regarding the cost that we might have to defray, or the $460,000.
Right.
And where we get that from is these costs to the individual and small group market, and then taking the percentage of those costs that would be applicable to the QHP. So about 93% of the individual market cost of about $485,000 is the lion's share of what we would be responsible for defraying, and then potentially about 1.4% of the small group cost of $600,000, and that's where we get to
what was the
total $460,000 that we could be responsible for defraying if the federal law were to preempt our prohibition on
that's our prohibition. Then was that figure then the $460,000?
That's right. So if federal law preempts Virginia law and we end up having to have the QHPs, it becomes a mandated benefit for these QHPs. It would take something that they're currently providing, and we would then be responsible for defraying it.
All right, and the 485,000 is the small group market, is that correct?
The 485,000, I believe, is the total for the individual market. Not all of that we'd be responsible for defraying because not all of those plans are, so some of those plans are off market and off the exchange and would not be considered QHPs for the purposes of defrayal. The total cost to the small group market is about 600,000, but since only 1.4% of those plans are QHPs, we would only be responsible for about $8,000 of that.
And who would be responsible for the other 452,000?
The payers of so the premiums would go up to cover that.
All right.
Within the small group market, the carriers would raise their rates based on their expected that expected impact.
All right, so then we would potentially be responsible for 460,000, and the plans and the individuals and companies that contract with them would have about a little over 1.5 million. Is that correct?
I think that's right. I believe that's right. If we take into account the large group market plus the small percentage of the individual market and all that taken together, I think that's about right. And then the real impact of that would be those per member per month increases in premium costs.
All right. Are there any other questions?
Mr. Chairman.
Yes.
Sorry, I wasn't not having the text in front of me. It's kind of hard for me to follow, but did I hear whether or not there was a prediction of exactly what the premium impact would be of adding $1.5 million onto how many thousands of policies?
I think there was 15 and 16 cents per member per month.
Got it.
That's correct, Mr. Chair.
Thank you.
Okay. All right, any other questions? All right. In terms of action, is it customary here, since most of us are new on the Health Insurance Reform Commission at this stage, to take action now on the prosthetics, or to wait until after the review of the other set of bills? Okay. All right, then we'll take it up now for consideration of a recommendation for the prosthetics bills.
You need a motion to approve the report? So move, Mr. Chairman.
All right, there's a motion to recommend approval of these bills. Is there a second?
Second.
All right, we have a motion and a second.
Mr. Chairman, so I understand the motion, this is for both bills or
No, this is only for the ones dealing with the prosthetics.
the prosthetics?
Right.
Thank you.
So the motion is before us. Is there any discussion on the motion?
Mr. Chairman,
Yes.
I would just, speaking to the motion, I would just say that, 15 cents per, I think it was per month, is that right?
Right. 15 in one category and 16 in another.
Okay, 15, 16 cents per month, and then my calculation's about a nickel per taxpayer, maybe 6 cents per taxpayer or something like that is really not a meaningful number. I'm sure saying that Mr. Gray might be having a stroke back there, but because I know all these things add up and they add up and they add up eventually, and you have to be cognizant of how many things you're adding. But to me, this is kind of
We got a motion.
not very significant, so I think it's something we ought to support. I have no idea where the body is, but that's my thought.
All right. Do you wish to ask a question of Mr. Gray?
No, I was just making Mr. Chairman, I was just making a comment because I know he's talked to me about this before, and I know that the cumulative effect of these things have a creeping effect on health insurance affordability and premium cost. But, you know, you're talking nickels and dimes here per month. It just doesn't seem like a lot to me, but somebody else might disagree with me. I have no idea what the sense of the body is. There's nobody saying anything.
Mr. Chairman, we have a motion on the floor, Mr.
Yes.
Sagamore.
Yeah. All right, are there any other comments or questions? All right, we have a motion to recommend approval of the prosthetics bills. Want to call the roll?
Delegate Goditis. Aye. Delegate Ware.
No.
Senator Surville.
Aye.
Senator Sproul.
Aye.
Vice Chair Heretic.
Aye.
Chair Barker.
Aye.
Ayes 5, noes 1.
Do we have? Okay. All right. Then we'll move on to the next set of step 2 presentation.
You have a quorum, I leave. Still have a quorum.
No. It has to be 3 senators. And okay. Okay.
Well, thank you again, Mr. Chairman. This time I will present the findings from JLARC's review of the proposed health insurance mandate for donated human breast milk.
Mr. Chairman, a question for him.
Yes.
Your presentation is longer as the first one?
I'm sorry?
Is your presentation as long as the first one?
As loud?
As long.
As long? I would say it's of comparable length.
You want a quorum, you know, if you keep on talking, we're gonna get out of here, you know.
I think he's saying he has to leave at a certain point, and it would be helpful if you would move through quickly, so.
I understand. Okay. You've seen this slide before, and so I won't go through this again. This just covers the questions that we answer as part of our review. Next slide, please. Mr. Chairman, this slide just summarizes our findings. At a high level, we found that pasteurized donated human breast milk is effective at reducing the rate of gastrointestinal disorders that are common in low birth weight infants, and it may also reduce the rates of other disorders in this population. Donated milk and fortifier are most often provided to very low birth weight infants in hospitals, less commonly on an outpatient basis. The cost of donated breast milk can be substantial, particularly when it's combined with a fortifier. These costs are generally borne by hospitals, but much less commonly paid for by patients out of pocket. And finally, the proposed mandate would give hospitals an additional revenue source to cover the cost of donated milk and fortifier, and it would assist patients with paying out of pocket where they're forced to do so. Next slide, please. I'll skip ahead to just some background information. Thank you. The bills we reviewed would require private insurance plans to the state employee health plan and the state's Medicaid program to cover pasteurized donated breast milk, as well as fortifiers. The bills have a number of requirements in order for coverage to be provided. Those are listed there on the slide. I will skip over those just in the interest of time. Next slide, please. Donated breast milk is often used to supplement or replace the mother's own milk when it's not available. And that can be for a variety of reasons, including that the mother can't produce enough milk in sufficient volume. Mothers often have difficulty producing enough milk for an infant when they're born prematurely, and in this case, as in others, the donated milk would be used as a bridge. Next slide, please. Donated breast milk is usually collected by milk banks and then provided to hospitals and infants. Much of it is collected by the Human Milk Banking Association of North America, or HIMBANA. There is one HIMBANA milk bank in Virginia. That's the King's Daughters Milk Bank, which is part of the Children's Hospital in Norfolk. And that is the largest milk bank in Virginia. Next slide. Quality guidelines are critical to making sure that donated breast milk is safe and free of contaminants. It must be pasteurized. Screening steps are required. And finally, the milk is perishable, and so it does have to be frozen when it's shipped or storage. Next, thank you. A mother's own milk is generally regarded as nature's perfect food, but low birth weight infants often need a fortifier added to that to provide them with additional proteins and minerals and other nutrients that they in particular need for healthy development. Those fortifiers are sold by a number of different companies and then purchased by hospitals. This slide just shows you the other states, at least 12 that we've identified that have mandates similar to what's being proposed here in Virginia. Next slide. And then I'll talk for just a couple of minutes about the medical efficacy and the use of donated breast milk. Donated breast milk and fortifier is often given to very low birth weight infants. These are infants that are born premature. They weigh around 3 pounds or less. They are relatively rare, but they are vulnerable to a number of different severe complications. The one I would highlight here is the necrotizing enterocolitis, which is a very severe gastrointestinal condition. Next slide. In looking at the medical efficacy of the donated breast milk, there is broad consensus that it's effective in treating gastrointestinal disorders in very low birth weight infants. There's strong evidence that compared to the use of formula, it can reduce the risk of necrotizing enterocolitis. And studies have also found that it can reduce the need for surgery among infants with that condition. And the medical experts that we spoke to essentially said the same thing, that the donated milk they're providing along with the fortifier is effective. Next slide. Donated breast milk may also be effective in treating other disorders that are common to low birth weight infants. There are a smaller number of studies that address its use for conditions like chronic lung diseases, retinopathy, and sepsis. And so there is a need there for additional research to confirm those findings. It is worth noting, though, that the medical experts we spoke to said that they do believe that donated breast milk with a fortifier may reduce the incidence or rates of these conditions as well. Next slide, please. Most of the donated breast milk and fortifier in Virginia is going to infants in hospitals, and in particular to those born with low or very low birth weight. The Children's Hospital Milk Bank in Norfolk is providing donated milk to about 20 NICUs around the state. About 3/4 of that is going to infants in an inpatient setting, whether it's a NICU or a newborn nursery. And then the hospitals are providing as well the fortifier. The slide at the bottom just gives you the numbers of infants that were served by breast milk at Children's Hospital in Norfolk. Next slide, please. Donated breast milk with a fortifier and fortifier are less widely used for infants in outpatient settings, and there's a couple of reasons for that. One, some infants are receiving more of their mother's milk by the time they're discharged from the hospital, and so the donated milk is more of a supplement. I should note, though, that in this case, the out-of-pocket cost of breast milk, donated breast milk, can still be a significant challenge for families. In addition, infants may no longer need the fortifier after being discharged, and that's because their gastrointestinal systems may have matured enough to be transitioned off of that product. And I'll turn to a couple of slides just on the cost of the proposed treatment. The cost of the donated breast milk can be substantial, particularly when it's combined with the cost of a fortifier. The cost of donated milk alone can be as much as $144 per day, but that will obviously be quite lower for newborn infants, for example, who simply take less, and it will also be lower to the extent that it's just supplementing a mother's own milk. Now, when a fortifier is included, the cost is substantially higher. For example, staff with one hospital estimated a total cost of $12,500 for both the donated milk and the fortifier for one infant spending 3 months in a NICU, and about $8,000 to $10,000 of that would be just for the fortifier alone. Next slide, please. In most cases, the cost of donated breast milk and fortifier is being borne by the hospitals. It appears that relatively few patients are paying out of pocket for that treatment. Staff with UVA and VCU, for example, said that their hospitals are generally absorbing those costs. And in the case of VCU, they estimated spending about $680,000 in FY21 to cover the costs of those products. I do want to take a moment and say that it is likely that some patients are paying out of pocket for the donated breast milk after the infant is discharged from the hospital. As I've said, in those cases, infants are less likely to need the more expensive fortifier, but the donated milk alone can be a significant expense, and to the extent that the infant would need the fortifier after discharge, that would be a significant expense as well. And these next few slides just talk about the coverage that would be provided by the proposed mandate. At this point, the insurance plans are generally not covering donated breast milk or fortifiers. TRICARE is the only insurance plan that does, and that is just for members of the military and their families. As of 2019, none of the 7 private insurance plans that were surveyed by the Bureau of Insurance were providing coverage of donated milk. This slide is just to remind you of the percentage of Virginians that are in plans subject to state mandates. I'll skip past that. If it was passed, the proposed mandate would mainly allow hospitals to treat more infants with donated breast milk and fortifier. Mandating insurance coverage would essentially give hospitals another revenue source to cover the cost of those treatments. Hospitals do have varying ability to absorb those costs, and many of them are limiting their use of donated milk and fortifier by prioritizing it to the smallest and sickest premature infants, so there would be less of a need to do that prioritizing if there was an additional revenue source for those treatments. I should also note that staff with CHKD, Children's Hospital Milk Bank, did not anticipate any difficulty meeting the increased need for donated breast milk if an insurance mandate was passed. That is a quicker version of the slides that I had prepared to discuss, but in whatever time remains, I'm happy to answer any questions.
Are there questions?
Mr. Chairman,
Yes, Delegate Goditis.
I was wondering if, so the fortifier is part of this. When this says necessary formula and enteral nutrition products, that's the fortifier.
Yes.
All right, thank you.
Yeah.
All right. Other questions or comments?
I have
All
a
right.
comment, Mr. Chairman, if no one else does.
Well,
I just want to say that, sorry,
Well, let me I'll ask a question first, and then
I just wanted to say if society wants these babies to be born, then it is society's duty to care for them in this way, in my opinion.
All right. Can you run by sort of the expenditure calculations? And
Sure.
like we did with the other one, so.
Let me find what slides those are on. If we can go to slide 18. And if you have it in front of you, you can just flip to it there.
Right.
But that slide mentioned the cost of the donated breast milk on a daily basis.
Right.
Could be as high as $144 per day. And that would be for an amount of donated breast milk that's most typical for an infant after they've been discharged from a hospital. So that was one cost figure. Another cost figure also on that same slide was an estimate from one hospital that the cost of donated breast milk and fortifier combined for an infant in the NICU for about 3 months would be upwards of $12,500, and that about $8,000 to $10,000 of that would be for the fortifier alone.
Okay. And then it would be the Bureau of Insurance that would have the cost, an aggregate cost for the provision of mandate here, and how much of that would be borne by the insurers and
Yes.
the companies that are providing the coverage, and as well as what the state might do, so.
Yes.
All right, are there other comments or questions here? Okay, does the Bureau of Insurance have a
Thank you, Mr. Chairman.
Set of comments as it relates to this particular?
Yes, Mr. Chair, let me share my presentation and we'll go through those.
Okay.
Oh, we're still sharing here. I'm getting preempted from sharing my screen because this other one's up right now.
Go ahead, Brad.
All right, thank you.
Yes.
Okay. Here is are you seeing it yet? We're still waiting for it.
We are.
Okay, excellent. So here is our step 2 assessment of the breast milk mandate. I won't touch on any of the issues that the sort of broader issues that we discussed before, only to say that we had similar challenges here with doing estimates, with not having this data from the carriers, and potentially with based on what their responses were, that an estimate would be maybe difficult to get without there being things a little better defined within the bill itself. So HB 2049 and SB 1650 from the 2019 session cover pasteurized donated human breast milk and human derived fortifier by private insurance companies in Virginia's Medicaid program. As Jamie mentioned before, insurance plans in Virginia generally do not cover this or the fortifier, but based on the JLARC research, they are being provided as needed to infants, with that cost currently being absorbed by the hospital. There may be some limitation of utilization based on hospitals' varying ability to absorb this cost across those hospitals. Utilization, it may be an overstatement here to say that it's not expected to change substantially, but at this point, at least our understanding is that the hospitals are providing this as it is necessary, but there may be some limitations on that. However, one of the issues that we run into with estimating utilization in this environment is we don't really know. The only number that we have in terms of the amount of this breast milk that's currently being used is the 176,000 ounce figure from Children's Hospital of the King Daughters. And we don't know how much may be coming from out of state or from other providers out there. And as we mentioned, we don't know what maybe the potential overutilization is, underutilization is under the current mandate. So in order to sort of make an estimate that we can ensure will be a high-end estimate, we actually doubled the Children's Hospital of King Daughters figure, and so we're going to estimate a high-end utilization of 352,000 ounces, and that is just in an attempt to ensure that we don't underestimate what the potential impact of requiring this is. With that, based on that estimate, we look to see carriers in the large group market could potentially see a 6.6 cent increase in their per member per month premiums. And if applied to all plans in the individual and small group market, there could be about a 7 cent increase in per member per month premiums there. The main aspect of that is that we, and also with these estimates, they don't just take into account doubling the Children's Hospital King Daughters amounts there, but in addition, estimating that all of that utilization would require fortifier, which does increase the cost per ounce from that $4.50 cost to closer to about $12 or $14 an ounce. These additional costs would apply in the large group market, where that 6.6 cents per member per month equates to $497,000 annually based on the 2020 enrollment. There are no QHPs in this market, so there is no issue with defrayal or with the segmentation of the market within the large group. In the individual and small group markets where we do have the issues with QHPs, the market cost for providing PDHM coverage, if it were applied to all plans, is estimated to be about $219,000. However, our prohibition on coverage would mean that about 93% of those individual plans would actually be prohibited from providing, I'm sorry, that says prosthetic coverage, PDHM coverage under Virginia law, which would mean that overall healthcare costs would increase in that market by about $15,000 with the 6.9% of individual plans required to cover. That said, these services are already being provided, and this breast milk is, for the most part, being provided to these individuals. It's just being absorbed by the hospitals. But in terms of what would be borne by individual market carriers, there'd be about $15,000 there that would be provided with that prohibition on the 93% of including that coverage. The small group costs are estimated at about $270,000 annually if it was applied to all plans. Only 1.4% of those small group plans are QHPs and would be prohibited from covering. So that would mean a reduction of a couple of $1,000s from that $270,000 number to something closer to maybe $267,000. A pretty minimal impact on the overall cost estimate there that's in the larger bullet. As we spoke about before, if Virginia laws apply as written, there won't be any defrayal costs as the coverage is going to be prohibited for QHPs. But if federal law were to preempt and PDHM coverage were mandated for the small group and individual markets, Virginia could be required to defray these costs, which we estimate at a high end of about $204,000. And that's the end of my presentation.
What was the last figures that you had there?
The last figures here are the potential defrayal costs if the QHPs in the individual and small group market were required to provide this coverage. The state could be on the hook for around $204,000.
$204,000, okay.
And as mentioned before, in terms of the impact on premium costs, the 6 to 7 cents that we're looking at there is based on double the known utilization that's currently going on, from the Children's Hospital of King Daughters. So it could very well be a substantial overestimation, but not having any better access to numbers there, we certainly didn't want to assume that what was being provided by CHKD was the entirety of the potential impact and potential utilization.
All right. Are there questions? Mr. Bitts, could you take a question? Are there indications that there are individuals in Virginia who are not receiving adequate care without, they're not getting the donated breast milk and therefore are impacted by that.
I would say, Mr. Chairman, a couple of indications, and they're both kind of anecdotal. It's hard for us to find numbers to attach to that, but we did hear anecdotally from physicians through VCU and UVA that there are mothers whose infants are discharged from the hospital and are sent home and are told or given a prescription to receive donated breast milk, but given the cost, that it can be a challenge for some of those families. I can't tell you how many, but we did hear anecdotes of circumstances like that. By the same token, families that go home with their infant after being discharged from, for example, a NICU or a newborn, well, in this case, I guess a NICU, who might need the fortifier along with the donated breast milk. Those also are anecdotes that we heard. Again, I can't put numbers to it, but we did hear instances of that. And in that case, that would be a much more significant and possibly prohibitive cost for families.
All right. Any other questions or comments on this?
Thank you, Mr. Chairman.
All right, thank you. All right,
Move to approval, Mr. Chairman. Then I'm gone.
all right, we have a motion to recommend approval. Second, we have a motion and a second. Any discussion or comments? All right, staff.
Delegate Goditis. Aye. Delegate Ware.
Aye.
Senator Searle.
Aye.
Senator Sproul.
Aye.
Vice Chair Heretic.
Aye.
Chair Barker.
Aye.
Ayes 6, no 0.
All right. All right. All right, next on the agenda is item 4, discussion of the legislation referred to the commission during the 2020 session. We wanted to see, there was presentation at our June 30th meeting that provided summaries of things that basically from the step 1, the movement in that direction for the bills, and that we have I think in the material that was sent out for a 4-pager, I guess, for each of those bills. There are options for moving forward to step 2 analysis on some of these, but we certainly can't do every one, and put JLARC and the Bureau of Insurance spending a lot of time doing that. So if there are any recommendations or discussion questions about any of these bills, now would be the time to bring those forward.
Mr. Chairman?
Yes, Delegate Ware.
Thank you, Mr. Chairman. The second bill that's listed there, House Bill 59, had been sent to the commission. Even though it does not add an additional benefit, it provides for a different category of provider to provide services, this being athletic trainers, providing services that are currently being provided simply by another category of providers. And it seems to me that since it does not add a benefit, and therefore, as noted in our chart, does not add a cost, it's something that we could move ahead with without further delay. So that would be my recommendation. I'm not sure what you would prefer as to how we move that along, but
well, certainly we could ask for a step 2 analysis, or you could make a recommendation just to move forward with recommend approval of the bill.
Well, Mr. Chairman, since, as I say, there would be no additional cost that would require analysis, either by JLARC or the Bureau of Insurance, it would seem to me that we could, if this body were willing to do so, it would seem to me that we could move that forward as a recommendation to allow a group that is certified in these same areas as in physical therapy. This would allow athletic trainers who are in their professional training, as we heard, prepared in this way, to be included as folks who could be reimbursed in that fashion. And Mr. Chairman, if you deem it appropriate, I would be prepared to make that as a motion
All right.
at this time.
You certainly can make it as a motion if you wish.
Well, I would so move, Mr. Chairman.
All right, is there a second? Okay, second, motion made and seconded. Any discussion? Any questions? HB 59, yes. All right, then I'll call for a vote on it if there's no further discussion.
Delegate Goditis. Aye. Delegate Ware.
Aye.
Senator Serval.
Aye.
Senator Spruill.
He's not here at the moment.
Vice Chair Heretic.
Aye.
Chair Barker.
Aye.
Ayes 5, no 0.
All right.
Thank you, Mr. Chairman.
All right, are there any others of these bills that anybody would like to recommend move on to a step 2, or any other motion that could be made? All right. If there are no other discussion on legislation referred to the commission during the 2020 session, then we'll move on to item 5. And on that, there were 4 bills, 2 of which I think were sponsored by members of the commission, Senator Serval and Delegate Goditis. But these bills dealt with insurance companies and the providers and hospitals, and both parties have said they did not want to move forward on these this year, and there will be peace in the valley for at least 1 more year, so if we can go forward in that direction. So unless there's anybody feels a burning need to stir up a fight where there isn't one already brewing, we can pass by this for the day. So, all right. Then the other item on the agenda is discussion of state deferral of the cost of the mandated benefits. We'd had a lengthy presentation on that at the last meeting, this is an issue that's clearly before us and is critical to being able to move forward on a number of potential issues in the future. At that meeting, there was substantial discussion and presentation from the Bureau of Insurance in terms of their discussions with the HHS officials who are sort of moving forward more aggressively in trying to implement what's already on the books, which does provide the responsibility of the state to defray costs under certain situations, rather than passing those costs on to the insurers and to the companies and individuals who pay the premiums there. The one thing that I think stood out from the discussion at the last meeting was the potential for dealing with these types of issues by consideration of revisions to the essential health benefits that are there, that we already have in place. And I think what was stated by a couple of people was that the benefits, the essential health benefits that Virginia has are not necessarily as extensive as what some other states might have. But that's sort of where we are on that. Is there anybody wanted to discuss how we should move forward with that issue in terms of any legislative solutions or options that we might want to consider. Well, I think one thing that I will try to follow up on with staff is sort of where things stand, how things are moving as it relates to the discussions between the Bureau of Insurance and the federal officials there, and then what our options would be in terms of review and consideration of essential health benefits, which could be an avenue to address some of these and get more clarity there and not be left in this limbo a little bit. If there's nothing further on that, then we do have...
Mr. Chairman, I have a question about that.
Sure.
So what are we just waiting for some shoe to drop on that? Or, I mean, is
Yes.
somebody going to write us a letter and say you're out of compliance? Or I mean, what kind of time frame are we on there?
Is there anyone from the Bureau of Insurance that wants to weigh in? Yeah, Julie, is Julie available? Yeah.
Yes,
Yeah.
I'm here.
Yes.
Thank you, Mr. Chair and Senator Serval. The Bureau of Insurance will be required, as well as all states, will be required to submit a report on our state mandated benefits as of July 1 of 2022. Once we submit that report, we need to let them know what we think is in addition to essential health benefits, and CMS will let us know if they agree or disagree. We don't know what's going to happen if they disagree with our determinations, but that will be the next step that we're aware of. We are, like we said, in discussions with CMS more frequently now, and we will be in discussions with them through the session, and we can discuss with them any bills that come up through the session to get a more definitive determination of how CMS would view it. If there is a difference of opinion, we're not sure exactly what would happen. I think CMS has kind of made clear that there wouldn't be potentially a retroactive penalty, but possibly, if a state is not making attempts to determine what is essential health benefits in accordance with what CMS rules are, they will take that into consideration as they determine how a state needs to decide this.
Mr. Chairman?
Yes, Senator Serval.
Okay, let me try and put a finer point on it. So I understand there's conversations going on, and there's dialogue and all that, and there's going to be more dialogue, and it's going to be dialogue and dialogue and dialogue. What I'm trying to decide is, at what point will there be a decision? And because, just to give an example, I have another bill I'm working on this session with child support where the feds claim we're out of compliance on our child support statute. And I would like to write the statute a certain way, and DSS would like to write another way. So we sent a thing to the feds and said, does Serval's idea, is that consistent with federal law? And they said, we don't give opinions. So I'm just trying to understand, at what date do we have to have a decision made to avoid prejudice to Virginians? Because I'm trying to get a sense of, is this a problem that has to be resolved this session, or is this a problem that can be resolved next session, or do we need to put language in a budget or some kind of enactment clause that says, if, as, and when this is going to happen, or what? So I get dialogues happening. That's really clear to me. What I'm trying to understand is exactly what the timing is and what the deadline is.
Yes, Mr. Chair, Senator Serval, do you want me to respond?
Yes, please do. And
I don't know that, I don't.
And bring, I think I heard you correctly that July of next year, you have to provide something in writing which will help move towards a decision, I think.
Yes, that's all we know at this point. That's the only date we know at this point.
Okay, Mr. Chairman.
Yes, Senator Serval.
So we're going to give something by July 1 or something, and then there's going to be some period of time where the federal government is doing something, And I guess I've heard that there won't be a retroactive effect, but there could be a prospective effect. And so I'm trying to just understand, like, is this something we have to do this session, or is it something that we can wait till the feds give us a clear answer after July 1 and do it in 2023? That's all I'm trying to get a sense of.
Julie, you want to try again here? So.
Yeah, and we don't know. That's just the bottom line is we don't know what the feds will do. It is up to the state to make the decision. They've made that clear, but if the state doesn't decide in accordance with federal law, and also as far as it being a retroactive decision, we've just heard verbally that it won't be a retroactive decision. There's nothing in writing saying it won't be retroactive. So there is always that possibility. And we just don't know a time frame on this.
Okay.
All right.
Thanks, Mr. Chairman. And
All right.
thank you, Julie.
All right.
Sure.
Any other questions or comments? All right. Then we will move on to public comment. And I think there are a number of people waiting to speak. We'll have a 2-minute time limit to the speakers.
At this time, I'd like to ask those members of the public who wish to comment who are here in person to please rise and approach the lectern in a line.
Okay. Mr. Chairman and members of the Health Insurance Reform Commission, I just have a few comments for you. And you got a lot of topics. In response to Senator Bell's question, Mr. Chairman, if you want to apply any of the mandates that you have recommended, you must act to change the statute to apply it in the individual market and part of the small group market, period. The greater issue is that the statute says you cannot require anything in excess of the EHB, period. If it said anything, you can require something in excess of the EHB if the state pays its share, then you can do all these other things as long as you put it in a budget amendment. And just for tradition's sake, when you look at each of these mandates, when you decide to favor one, you are saying you are going to do it in the state health plan, you are going to pursue it in Medicaid, and you're going to pursue it in the exchange. All of those are connected to one another. And so how you do a mandate is important. So, for example, when you talk about the concept of doing something on prosthetics, the way the bill was written, it takes medical necessity and makes it a code in Medicare and puts it in the law. Never happened, ever, ever. Medical necessity is determined by standards set by outside professionals and used by health plans to make decisions in conjunction with the physician. So it's how you do it. That matters quite a bit. It can't be just because there's a Medicare code. That is a huge change. And to say that that suffices for medical necessity is not appropriate. Same thing with donated breast milk coverage. It has to be medically necessary, and there has to be a standard. The entity that's producing it needs to be licensed. If you're going to transport it, or store it, or deal with it, there have to be standards for that, and they have to be followed. It can't be just anybody. There's one milk breast bank here in the state, period. Right. So how do we deal with the out-of-state ones? These are all things that have to be dealt with when we write a bill. If you want to compensate an athletic trainer, you might want to deal with the issue of whether they're employed on a salary by a school. Are you intending to reimburse the school for their services from Medicaid, from the state health plan, from the exchange? Got to think those things through. So how you write each of these things matter. But in the greater scheme of things, you have a children's hearing aid mandate that you'd like to do. You have the formula mandate, which we've already passed. And then you've talked about 2 others today that you'd like to do. You really can't move forward until you make a decision on the greater issue. Either that or figure out how to change the essential health benefit to include them. And that process is long and involved, and we did discuss that at the last meeting.
Right.
So I would suggest to you that Senator Cervella and through the chairman, that if you act to change the statute to say you will be able to require it in the exchange if the state has paid their share, then you have a path to move forward. And whether they actually demand the payment, which I think is what Senator Cervella was asking in his questions, is another question. And if they do, you'll have to pay it. If not, you won't. But you can then be in a position to determine policy. So I hope that helps kind of bring some context to the whole process. And I just want you all to know, we don't oppose, for example, using donated breast milk. It's appropriate in many circumstances, but it's not appropriate without basic requirements built around it. And those are lacking.
Right.
And there is controversy about whether you license a breast milk bank. Do you pay the people who donate the breast milk? And some states actually pay for it. And so you can see if you mandate it and there's only one, oh, what happens next? And that affects your cost estimates. So, these are all basic things that have to be dealt with. So just from a process perspective, we can think through those things. And thanks for letting me have an extra 15 seconds since I covered 5 different topics. And I'm glad to answer any questions later.
Okay. All right, thank you. And we will certainly deal with some of those through legislation, I presume. All right, next.
Turning now to our virtual public commenters, I'd like to remind them, if you are presently in the Zoom room as an attendee, you have registered to provide public comment, and you will be called on to provide that comment. If you do not wish to provide public comment, please exit the Zoom room now. And you're welcome to return to the Virginia Senate live session video stream webpage. And instead of clicking on the public comment registration link, please click on the link that reads View Event next to the meeting name. Once you have been called, please unmute yourself and begin your testimony immediately. And I'll remind you that the chair has granted all of our commenters 2 minutes to speak today. Tiffany Jefferson, I'm promoting you to panelist now. You're welcome to begin immediately, and Asia Moore will go next.
Hello, good afternoon to the Health Insurance Reform Committee. Thank you so much for this opportunity to speak with you all virtually on today. I am here in support of HJ 545, mandated coverage for infertility as well as fertility preservation. I am requesting that HJ 545 be given the go-ahead for a step 2 analysis. According to the American Medical Association in 2017, infertility was recognized as a disease, and there is increasing activity by state and federal governments to improve access to infertility treatment. 19 states have fertility insurance coverage laws, and 13 of those states mandate IVF coverage in fully insured plan offerings. A 2021 Mercer survey on fertility benefits showed that offering infertility coverage has helped achieve the following outcomes. Offering infertility coverage ensures that employees have access to quality, cost-effective care. They stay competitive in attracting and retaining talent, and this is for employers. Employers are recognized as a family-friendly employer. This also supports diversity, inclusion, and equity efforts, as a majority of people who are facing infertility are African American women and people of color. This mitigates the risk of high-risk pregnancies and produces positive public relations. I think we have an opportunity to make Virginia one of the great states that offers infertility coverage. We will attract more people to our state. It will boost our economy and workforce. And I think that there are so many benefits to adding this coverage. We have looked at how expensive it can cost or how expensive it can be, but in the grand scheme of things, when you compare it to other health needs and things that we provide coverage for, the cost is very minimal. So I please ask that you consider studying and moving forward with step 2 analysis. Thank you so very much, and I really appreciate your time and your consideration.
Thank you. Thank you very much. Who's next?
Barbara Kalur, I am promoting you to panelist now. Don Beatty, you will be next. Barbara, whenever you're ready, please unmute yourself and begin.
Hi there. Thank you very much. Thank you very much to the panel. And I too am here to speak about HB 776. My name is Barbara Kulora. I live in Herndon, Virginia. I am also the president and CEO of Resolve, the National Infertility Association. We are a nationwide patient advocacy organization founded nearly 50 years ago, and we happen to be headquartered in Northern Virginia, right here in the Great Commonwealth. And I think it's important to also note that the first IVF baby born in the United States, as I'm sure you've all heard before, was born here in Virginia at the Jones Institute in Norfolk. Her name is Elizabeth Carr. She will be turning 40 on December 28th of this month. So 40 years we have had this great, amazing medical treatment, and yet in Virginia we still don't have coverage for it. I understand that there are so many issues and questions around the Affordable Care Act, the essential health benefits, and defrayal issues. We would like to continue to work with the chair and with all the legislators, with JLARC and others on this really important issue, because Virginians want to build their families and they deserve to build their families. Neighboring Maryland has had this coverage for nearly 35 years. They have updated their mandate for IVF coverage 5 times in those 35 years to make it more inclusive and more comprehensive. I think that it's time for Virginia to take a very serious, hard look at coverage for Virginians to build their families. So again, I want to encourage this commission to advance HB 776 for a step 2 assessment. Thank you.
Thank you.
Joyce Renecki, whenever you're ready, please unmute yourself and begin. Our last public commenter today will be Tiffany Jefferson.
Hi, thank you so much for including me today. I want to thank Chairman Barker and all of the panel members. I'm here to speak also on behalf of HB 776. My name is Joyce Reinecke, and I am here before you as the executive director of a national nonprofit organization called the Alliance for Fertility Preservation. And we are dedicated to helping cancer patients understand and also navigate the reproductive consequences of their cancer treatment. So that is one aspect of the bill that isn't included in 776 is fertility preservation services. So although I'm here in my professional capacity, I am also a cancer survivor who faced this issue myself. And I guess you would say I was fortunate to be in my 20s, diagnosed with a rare cancer. And fortunate, I say, because I was able with my husband to raid our personal savings and be able to afford fertility preservation services. And I now have twin daughters who are in college. So that was quite some time ago. This experience really redirected my professional life. And I just want to share with you that over the past 15 years, I've met hundreds of cancer patients and survivors and family members. And I've heard about their fears, not only about their cancer diagnosis, but about their ability to one day start their own family and retain their fertility. So as you just heard, and I'm sure you all know, much of the technology that allows for these services for sperm banking and specifically for IVF for women was pioneered here in Virginia. And each year, there are approximately 4,000 patients in Virginia who are diagnosed with cancer, either in or before, so this includes children as well, their reproductive years. So access to those services that they need to preserve fertility for the future will remain out of reach for so many of those patients if they continue to be denied insurance coverage for these medically necessary services. And I really would urge you to move this bill forward for that step 2 analysis so that it can be introduced next year, because for these patients, they simply do not have time to wait. They can't fundraise and save up for fertility treatments because they're facing urgent cancer treatment. And the cost of forgoing those fertility treatments, if they have to pay out of pocket and can't afford to do so, for many is sterility. It's permanent, permanent effect of their cancer treatment. The good news is it doesn't have to be this way. And in the past several years, many states have enacted this coverage. And so we would urge you to do that. In addition, the Federal Employees Health Benefits Program will start this coverage January 1st. And the Veterans Health Administration has fertility preservation in place.
Wrap it up, please.
Oh, yeah. Thank you so much. I would really just say that these patients can't afford to wait. So I would urge that you put this forward for step 2 analysis. Thank you.
Thank you.
Mr. Chair, there are no further persons in person or virtually wishing to testify.
All right. Is there anything else anyone wishes to say or propose? All right. We have a motion to adjourn. All right. Motion and a second to adjourn. All in favor say aye. All opposed, no. We are adjourned.